Good afternoon, everyone. This is Michele Hughes from Ageless and Timeless. Well, I have a wonderful guest today. I always say this because I always get the best guests that are on my radar. And Dr. Yurth is our guest today, Dr. Elizabeth Yurth from Boulder, Colorado, and she's one of the co-founders of the Longevity Institute, which she's going to tell us about in just a moment. But I just want to say that the reason that I've invited Dr. Yurth is because I had looked at, I always look at the podcasts of other hosts just to see if people are focusing on some of the same subjects that we think are important. And one of those, as you all know, I've been doing several podcasts on peptides. And I noticed as I looked through the various podcasts on YouTube and on Instagram, and so, well, mostly YouTube, I found that Dr. Yurth was a real expert in peptides. So we're going to talk about peptides today, but in the beginning, I'd like to get an overview so you can understand who she is and what she does and why we think her experience and knowledge is so valuable. So Dr. Yurth, welcome to Ageless and Timeless.
Thank you, Michele. I appreciate you having me on.
You are welcome.
I will say I came to this in a very roundabout way because I came from an orthopedic background, and most orthopedists want nothing to do with medicine. In fact, one of the reasons I left my orthopedic group finally after 30 years almost was the comment that when somebody asked why I was ordering labs and looking at all hormones and things on my patients, I said, well, because that's all part of healing. And they said, we don't do medicine here. We do orthopedics. So, fortunately, orthopedics is a little bit in the sort of backwoods as far as longevity medicine goes. And so about 17, 18 years ago now, having practiced orthopedics for a long time, was sort of frustrated with we'd patch people together, they'd come back never really quite being 100%, then we'd patch them together, and they'd come back and we'd patch them together, and finally you'd replace a joint, whatever. And you really felt like people never truly got healed. And so I started to look at, can we actually make people truly heal? And that was going to entail looking at nutrients and looking at exercise and looking at hormones, because that's such a neglected piece of us being able to heal from injuries. And so as I started to learn more about this, I thought, gosh, I got to go learn more. And this was back, I know you're a big part of A4M. And this is back when A4M was really a small group of doctors. It was, 17 years ago, there was not very many people in the crowd. Now it's grown to thousands. But I went, sort of searched it out as the place to learn more about hormones and functional medicine. And so I went and did a fellowship through A4M. And then I sort of wore two hats. I practiced at my orthopedic clinic during the day, and then I had Boulder Longevity Institute in the evenings, and I would come and see patients here in the evenings, and I would sort of try and do my 15-minute appointments in orthopedics and not tell people everything, just try and get them at least introduced to it, and then people could find me here if they wanted and come and see us here. So then about 2 years ago now, I really said, I can't wear both hats anymore. And so we brought the orthopedic practice into Boulder Longevity Institute. So now the clinic is actually, we deal with the whole body, with everything getting well, but a lot of people come to us from an orthopedic perspective who aren't doing well, or who have acute injuries. We're in Boulder. We have a lot of athletes. We have a lot of very high level athletes. So, who want to get better fast. They need to get better fast. So trying to give them tools to be able to recover more rapidly. And a lot of them are really, when you look at these high level athletes, a lot of them are very much challenged hormonally. They're overtrained, things like that. And so we combined the whole longevity health piece into the orthopedic piece. And, and we have some people who just see us and, want regenerative procedures on a knee or something like that. But for most part, we try and get people into the paradigm that if you get yourself healthier and focus on the joint as a part of that health, that the joint will follow. So that's kind of how I got here.
That is such an important piece, because so often, as you said, athletes haven't focused on the anti-aging or the longevity aspect. So what happens when an athlete is seriously injured and you want to introduce them to all the techniques to get better faster that are part of the regenerative medicine practice?
I think that's tough, because a lot of the athletes have, they're familiar with things like peptides, right? So a lot of them have been in the reading, they read about BPC 157, which is a peptide that really helps with healing. And they've bought it online from some research chemical place. And so, they've sort of touched on some of these things. They've done reading, they've looked. And so some of those things have circulated around. One of the problems with peptides in the professional athlete world is they're all pretty much banned. So you have difficulty with that. But in the more amateur athlete world, they would search these things out and find them, but they would be using them relatively inappropriately, sometimes from sketchy sources and things like that. But so let's say somebody comes into us, they've just had a anterior cruciate ligament tear in their knee, and it's been surgically repaired, and they told them it's going to be, 9 months before you can get back into your sport. Well, so our goal is, how do we, number one, hasten that process, but number two, make sure you actually get into your sport. Because I think a lot of people don't know that even something like an ACL tear, and I've torn my ACLs 4 times, 2 on each knee. An ACL tear is not simply, oh, you fix it and you're better. In fact, 80% of people who tear their ACL, even if you're 16 when you do it, are going to have osteoarthritis by the time they're 50. So we know that something starts in that process, and that if we don't nip that in the bud, then these people are going to go become debilitated. And I can tell you, I tore my first ACL at 16, and subsequently more and more after that, and finally didn't even repair them because it wasn't working for me. And my knees are horribly arthritic, but because of what I do, they have zero pain. I'm totally functional. I can do everything, even though if an orthopedic surgeon put on my knee x-rays, they'd say, oh my gosh, you just need these replaced. But I have no pain, totally functional, and hopefully regrowing cartilage. So basically, let's say you come into me, you've torn your ACL, your surgeon fixed it, and you want to get back. One of the first things you have to do is, number one, make sure that there's the hormones on board to help joints and ligaments heal. So, I know you've talked to some of your guests about hormones, and I think one of the things we forget is how imperative hormones are in both men and women to healing an injury. For ligament healing, you need to have estrogen on board. You need to have progesterone on board. This is men and women. So when you look at these athletes who are oftentimes overtrained, and their hormones, like a lot of them, their hormones are not very good, you need to make sure that is all optimized. Now, the next step you always have to do with these people is basically teach them that what happens when you have an injury, just like a viral illness, like let's use our favorite virus, for example. So basically you have a viral illness and your body is supposed to react to it. You're supposed to get a fever. But if it sticks around, that's a problem. So if inflammation comes and it just stays, that's a problem, right? What we want is a little inflammation. We want it to go away, and we want to start healing. But most of us maybe don't have all the nutrients we need, or maybe our genetics are just as such that we get this escalation of these inflammatory proteins. And instead of going away the way they should, they basically stay elevated. And when they stay elevated, right then and there, you start destroying cartilage. So we'll use things that will actually blunt some of those bad proteins and some of the bad enzymes that have started destroying your cartilage right there at that time of the injury. And those things.
And what are they?
So one of our favorite go-tos is actually it's called a repurposed drug. It's something called pentosan polysulfate. So pentosan polysulfate, which is coming to the U.S. as the drug xylitol, been used in other countries for quite some time. Here in the U.S., we have an oral version of it. It's called Elmeron, and it's used for bladder inflammation. So the oral version for bladder inflammation, however, has 2 problems. Number one, you have to use a relatively high dose of it to get efficacy. And number 2, what they found, and they've been using this drug since the 50s for bladder inflammation, for like women with cystitis or men with cystitis. What they found is they're just starting to see these cases now. So, years and years later, but cumulative doses of this drug at a high dose, people started to develop this weird retinopathy. So damage to their eye that was irreversible. And so the drug, pentosan polysulfate or Elmeron, actually has a black box warning about it. But what we know is that as a different drug called xylitol, as an injectable subcutaneous, you can microdose it. So just like microdosing all those other things you hear about, psilocybins, you can microdose the pentosan polysulfate. So you never reach those threshold doses that cause the retinopathies. And likely the subcutaneous injections at this point, it looks like don't even cause that even over long term. So xylitol is being pushed through rapidly. Phase 3 trials here in the US are doing a big study with NFL football players, ex-NFL football players on it. It will probably come to market in a few years, but we've been using it for about 3 years because it is a drug that's available as an oral form. We can have a compounding pharmacy very easily make it into a low-dose subcutaneous injectable form.
So how do you compare that with BPC 157, which has no side effects? And are they doing the same thing? Or
no? So BPC is great, right? So BPC, body protective compound, works very differently. It is great for healing, and I'll use it in concert with Penticin. But Penticin in the studies, and there's nothing else that does this, over a period of time, they just released the year follow-up on this drug in March, that they saw 37% improvement in cartilage space on knee x-rays. 90% of people had substantial improvement in arthritic pain. Even these were people who were actually headed to joint replacements. No complications. The placebo group had about 4 to 10% loss of cartilage space. And again, when do you see improvement in cartilage space? You just don't. BPC is not going to help you to regrow cartilage. BPC is very anti-inflammatory. It helps repair. It's better for soft tissue than it is for joints. So it works better for soft tissue healing. So like tendonitis, things like that. But when you're looking at joint arthritis, it doesn't do some of the things you need, particularly when you look at what propagates after you tweak your knee, you have an injury. What propagates your body starting to destroy the cartilage are an enzyme called metallomatrix protease 3, MMP3. I always like to think about MMP3 sort of like it's coming in. It's the guy you get to come and clean up the mess, right? So big old mess. You've got to have somebody come clean up the mess. So it's coming in. You've got all these dead white cells from the inflammation. It's trying to clean up the mess. The problem is, much like a spot on your wall, if it stays, it keeps cleaning, it keeps cleaning. And if I kept cleaning that spot on my wall, eventually the wall would be gone.
Today's podcast is brought to you by Water and Wellness. Water and Wellness is one of the best companies to find purified water. They have a countertop system that I use, and I travel with it all the time. So I would highly recommend you look at that. If you use the Ageless code, you'll get a 10% discount. waterandwellness.com/pages/Ageless and Timeless. That's how you can order to get the discount. So visit waterandwellness.com or call 877-296-6880 to learn how to take control of your drinking water and learn about all those natural additives to optimize your health and longevity.
So, but Dr. Yurth, can you, with any of these protocols, can you help the athlete to avoid surgery?
If you have a complete ACL tear, my feeling, and I know there's some regenerative doctors who disagree with this, think you can really regrow. I think if you have a complete ACL tear, you should fix it surgically and then follow that with a mechanism, with a treatment plan that keeps you from progressing to arthritis. Now, where we can avoid surgery and where I think we will see, when you look at this drug that's been used in Australia now, they've reduced the need for joint replacements by almost 90%. What we will see is that we can really dramatically change people's course to a joint replacement. I mean, there's people who are just too far gone, but if I can catch you at an earlier stage, if you're at like a stage 3 arthritis, so you're severe, you have a lot of pain, the only answer is a joint replacement, but there's still a little bit of work to work with, you're going to do great with Penticin. So that's where we can really avoid surgery. If you have an acute or a meniscal tear, for instance, meniscal tears should never be, you should not have surgery on a meniscal tear unless you're 25 years old or 20 years old. In fact, in every other country, surgery for a degenerative meniscal tear is banned. You can't even do it because it's been shown to be such an ineffective surgery. And here in the US, it's one of our number one surgeries. Is going in there, you tear the meniscus, you go in, your knee hurts, you tear your meniscus, and the doc's like, well, we'll go clean that up. And I always tell people the old, let's just clean up your knee. But like your dementia patient coming to you and the doc going, let's just go in there and we'll take out those bad pieces of the brain. It'll all be fine.
Right.
It's exactly the same scenario. So where we can avoid surgery is degenerative meniscal tears, osteoarthritis progressing to joint replacements. I think if you have a complete rupture of a ligament, putting the ligament back together is still important, reconstructing the ligament.
And what do you think about titanium when you break, let's say, an ankle or your foot, and you need to have titanium screws and implants? So, what's your thought about titanium? Is it a good solution? Is it long term? Do you need to eventually have it taken out in order
I think
to
typically
heal?
we're going to have to use hardware. You have a fracture, you're going to have to use hardware to fix a fracture, right? So if the fracture needs to repair, you're going to have to use hardware. In general, titanium is pretty benign. There are people who have reactive changes to things, right? So there are people I see who have inflammatory changes to almost everything you do. We see this a lot with joint replacements, people who have nickel allergies, for instance, things like that with joint replacements. But even titanium, which is probably the safest of the metals that we can use, you do see people who have reactions, right? That come in and they have a lot of pain and they have a lot of inflammation. And you can actually run some labs on them that show that they're having sort of an immune reaction here to the hardware. A lot of times we end up taking the hardware out on those people anyway, simply because the hardware itself is sometimes painful and there's no reason after a certain point to have it in there. So a lot of times we end up taking that anyway.
Well, let's jump over to the regenerative side, because there's so many subjects I want you to focus on with our viewers today, and I know before I know it, we'll run out of time. So let's talk generically about aging. What is aging, and why is it important, or is it a disease, or what? How do you define the term aging? Let's talk first about that, and then about biological versus chronological aging.
So I know you had Ryan Smith on recently, who talks a lot about, measuring biologic age versus chronological age. So when you look at aging, I, along with probably most people that you've talked to in our field, consider aging a disease, right? It is basically that everything that kills us, cancer, heart disease, kidney disease, dementias, those are all higher. They get higher and higher as we age. So ultimately, the disease we're trying to treat is aging. We're trying to not see this organ system decline. And there's a universal problem at a cellular level when you look at aging. And I think this is when you look at functional medicine, where it says, okay, well, you're fatigued. Let's look at the adrenal glands. So I think that functional medicine is becoming a little bit now the way traditional medicine was. It's getting a little behind the scenes. So myself, I'm on faculty with a group called SSRP, or Seed Scientific Research and Performance, and we're trying to teach a new kind of medicine called cellular medicine, where you actually look at the function of the cell and what's going wrong at the cellular level that's promoting all of these disease processes. And it can really come down to some very basic things. Number one is mitochondrial dysfunction. So our mitochondria they stop working well, right? You think about the tissues that are the most dense. Remember, all your listeners, mitochondria you learned in high school, they're basically the energy powerhouses of the cell. They make all your ATP, right? That's how it's going. As we get older, we get less mitochondria, and we also get more dysfunctional mitochondria. We get more damaged mitochondria. And that screws up this balance we have, what's called redox, this balance between reductive and oxidative species. And basically, once that balance gets screwed up, you start screwing up a whole lot of down things. So almost every disease, cancer, heart disease, brain disease, you can link to mitochondrial dysfunction. The tissues that are most mitochondrial dense, that use the most energy, are your heart, your skeletal muscle, and your brain. So those tend to go sometimes more rapidly than other organs, right? You see, one of the first things you see when people age is they become sarcopenic. They start losing muscle. And part of the reason is that they're getting this mitochondrial dysfunction in the muscle. You can't get energy to the muscle. So we really look at trying to repair this sort of the cell at that level. And then the other piece, and this all kind of ties back to the cell, is that once you start disturbing all these processes, you actually start getting immune dysregulation. So what you'll see is that there's a hyperimmune state where the body is not learning to attack things like viruses anymore. Instead is attacking yourself. And so we know this dysfunction or loss of immune function is a big piece too. If I look at any disease, I start with looking at mitochondrial function, what's called peroxisomal function, because those are the things that help you make energy. And it's a very cool test that most people don't know about, designed by one of my good friends, Dr. Dane Goodenow, who, if you can have on the program, you should, because he's incredible. He wrote the book Breaking Alzheimer's, and he is one of the most expert biochemists you'll ever speak to, but can actually speak like a normal person. And he designed a test that's one of the only tests that we can utilize to look at where the cell is failing. So we kind of call it our systems check for the cell. Get what's going on with the mitochondria, what's going on with the cell membrane, what's going on with the myelin, what's going on with the peroxisomes that are, again, helping carry fatty acids. So we can actually look at these very specific fatty acids and lipids and decide exactly what's going on with the cell. So just like your car, sometimes you take it in for a systems check, right? Because you don't want your car to be in the middle of the desert and now it just all dies. So basically, if you can catch those things early, and this is way before they present with any diseases lots of times, right? Then we can fix them. We can fix the mitochondria, we can fix peroxisome. So, but a lot of that is repairing the cell at its very base level.
And is that a blood test that you do?
Yeah, it's a blood
Dr.
test. It's called a prodrome scan.
Prodrome. How does that compare with what True Diagnostics with Ryan Smith does with the DNA methylation and telomeres?
So very different. We're again trying, whereas, the problem I think with a lot of the aging tests is you get back this number, right? And they say, and I don't know if you've gotten one, but, you say, oh, these people get these results. Oh, I'm 5 years older than my chronological age. And, and then you look at their little recommendations, which is like eat more fish, exercise more, and you're like, I'm doing all that. Now what? This doesn't make any sense, right? And I get that all the time. I have people who look in optimal health and they're great. And then they come back with this number on methylation stage that doesn't fit. And I don't know what to do with it, right? We have to have some answer to what to do with that. So I think, and particularly, adenosine rate of aging is probably more important than methylation age, but I think that those numbers are somewhat important. And Dr. Goodenow will argue that we actually don't quite know when we're measuring things like that, what we're measuring. So should my DNA methylation look the same at 62 as it did when I was 20? Should it look the same? Is that ideal? Or have there been cellular adaptive changes that have occurred that are actually benefiting me, right? So we're basing this number on, okay, this is what it should be because this is what it looked like then, as opposed to maybe there's adaptive changes that are good for me. They're actually what's keeping my cells a little bit more functional, right? So there's a lot of things we don't know. And I caution your listeners to just go, oh, methylation age is everything. I don't think we have that answer. I think the answer is going to come down to more when we get some of the combinations of methylation age, DNA methylation with proteomics, with metabolomics, but that test doesn't exist yet, So I caution people, we also don't know that what you're measuring in these tests is true for every organ system, right? Because, that's a big piece too. So I don't use that test much in my clients. I think Ryan's brilliant. And have a lot of respect for the test, but I don't use it and I don't recommend it in my clients. My goal is to make their cells as healthy as possible. And, and if I am doing that, in all likelihood, I am delaying their aging no matter what my DNA methylation age shows.
Well, then what I'm hearing you say is that all aging begins in the cells. And that's where we want to...
Primarily the mitochondria.
Right.
Which is the heart piece of cell, right?
That's the heart of the cell.
Right. And when you screw that up, we've shown cancer is a mitochondrial disease. You could take a cancer, and if you put a normal cancer cell, and you take a normal mitochondria and put it into the cancer cell, you'll make the cancer cell normal again. So we could transplant normal mitochondria in every cancer cell, we could make them normal again. So we know that the mitochondria are carrying this information, and that screwing up the mitochondria is where things go awry. And and so when people all talk about, for instance, NAD, right? You probably heard, okay, NAD drops as we age, and so and so pump more NAD back in, and all's going to be well. I'm giving a big lecture in a month on this because that's so untrue. NAD levels actually don't drop as we age, but what happens is the NAD gets stolen away and more utilized by old senescent cells and cancer cells and damaged cells. They want NAD. So they upregulate enzymes to steal your NAD, right? And give it to these bad cells. I throw more NAD or one of the precursors into the mix than I do. Over time, I'm actually feeding the senescent cells and the cancer cells, and your NAD pools, didn't really go up at all. In fact, it's been well shown that, NAD pools, they stay static. If you block the enzymes that are depleting NAD, the NAD pools don't change in us. We don't make less NAD. What we do is we drain more, and it's primarily because of the damaged cells. So we have to repair at a different level. We have to repair the enzymes that are upregulated by the damaged cells.
Does NAD have any influence, negatively speaking, on estrogen levels?
When you give supplemental NAD?
Yeah.
Well, so, and remember, NAD itself can't get absorbed into the cell at all. So when people are doing NAD IV infusions, what happens, NAD has no way to get through the cell, can't get through the cytoplasm cell, it just floats around in the serum, but it converts into NMN and NR, and then those go into the cell, right? And particularly NMN is then the sort of the precursor that then gets into the mitochondria and gives NAD. And then you've got these enzymes, something called CD38 and NMT, that are draining it. Now, if I'm draining my NAD stores and feeding in the cells, does that actually affect my hormones? Well,
right.
Indirectly, yes. It's a pretty downstream effect.
Okay.
So I think, like correcting the NAD in and of itself. But when you do blockers of the enzymes that are stealing the NAD, you do see people's hormones stabilize.
I took NAD one time IV, and boy, I never get ill, but it really affected me. Like, I had to tell the doctor, I think I'm getting like nauseous. Why is that? What is it in there that makes people have that reaction?
Because the NAD initially creates this big inflammatory response. So you get this actually big inflammatory response. Some people like that. That's what they sort of, they feel hot, and they feel like they're getting all this energy. It's actually this release of all these, what we call damage-associated proteases or proteins, DAMPs and PAMPs, are these proteins that get released acutely when you release the DNA, or the NAD. So there's an acute inflammatory response. Now, that usually goes away, but that's not a good thing. And people have sort of misinterpreted that as, wow, I felt all this energy surge. Yeah. It felt hot and red and sort of.
Yes, like taking niacin.
Like taking niacin, exactly.
Yeah.
And yet, and again, if you do one NAD infusion, you're probably fine. But if you keep doing these infusions, I can well show people how you are feeding cancer when you do that. It's not a good thing to do. So this is that whole understanding of sort of this balance in our cells, and we can't just say, oh, this is getting lower, let's fix this, put all this in, and all be well. It doesn't make sense. You've got to change the pathways that are creating the problem, the pathways that have gotten disrupted as we age, right? And I'll say the same thing is true about DNA methylation. Some of those changes may be changes that are occurring to help us a little bit, right? That they're actually trying to deal with some of these stressors that it sees happening. So is it necessarily a bad thing? Nobody really knows the answer to that.
So why do you need to take a precursor? Like, the same question I have about 5-HTP and tryptophan. I mean, why can't you just take NMN and tryptophan as two examples of the end result of the precursor?
So
is there a reason?
NMN is a much better way to replace NAD than giving NAD infusions, because NMN has a direct ability to get inside the cytoplasm of the cell, into the nucleus. But again, what happens now is that any excess, so your body uses what it can, and then if you keep feeding it, it's called the salvage cycle. So it forms nicotinamide. Okay, nicotinamide is designed to go back and form more NAD, but my NAD stores are already full. Nicotine doesn't go that pathway. Instead, nicotinamide needs to get excreted. It's because your body's like, oh, I've got too much NAD. I don't need it. You keep feeding NMN in. Okay, NMN's raising the NAD levels. Now it's gotten too much NAD inside the mitochondria, for instance, and now the NMN turns into nicotinamide.
Mm-hmm.
It's designed to recycle, make more NAD if you need it. If you don't need it, it's designed to excrete it.
It'll be excreted.
It gets excreted, but excreted by an enzyme called NNMT.
Oh,
And NN, which is a niacinamide methyltransferase enzyme. So NNMT is it's very upregulated in a couple of cells. Number one is fat cells. Number two is cancer cells. They love NNMT. So when you upregulate NNMT, because you've given so much NAD precursors or NAD, and now you have too much nicotinamide, now your body's trying to get rid of it, then basically, what have I done? I've now feeding cancer cells and I'm feeding fat cells and making people more obese or metabolically unsound. In fact, if you look up NNMT blockers, they're one of the big research places that we're looking for cancer. Because if you block NNMT, you actually can stop cancer. So we're feeding NNMT into these cells, right? To try and get rid of it, but it's not. It's now you've upregulated so much that your body is feeding it into the cells you don't want it to.
That is so important what you're saying, and I don't think I know most
nobody knows it. Nobody knows
Yes.
it. Everybody's out there, preaching to take these NAD precursors. Nobody understands, and that's what we're trying to sort of teach is with the cellular medicine is understand these pathways, because the only way to know that you're not doing harm and that you're actually doing some good is to know these pathways. So what do? I use NNMT blockers, right? So basically, if I want my NAD to stay where I want it, I don't want to form. And what I use is one of the really good. So it's all getting a little too biochemical, but the niacinamide can either go into a bad product and screw up methylation, or it can turn into a good product called 1-methyl nicotinic acid, or 1-MNA. And 1-MNA is basically really good for us. It helps, but makes us more metabolically sound. It increases our searching. It's really good, right? So if we could just get 1-MNA without turning on NMMT. So what we do is, and there's only one place to get 1-MNA, and that's from a company in Poland. So we've been working for the past 2 years with a company to bring 1-MNA to the U.S. To U.S. market, because it is truly, you get all the good sides of NAD from the 1-MNA. It does all the same things, blocks the NNMT enzyme, so you reduce cancer, you reduce obesity, you reduce all the bad stuff, you improve methylation, and you don't have to go stick too much NAD into the cell and have no idea what you're doing. So that's the way understanding these pathways work. So we had to search long and hard to find a product, somebody who made this. Like, we wanted 1-MNA,
right?
And interestingly, this company in Poland who makes it was trying to bring it to the U.S. as a drug,
right?
And we're like, you are going to take 10 years to get there. Let us bring it as a supplement. So we've now so we should actually have that supplement here in the U.S. available, hopefully within the next month or so.
That is so important.
Process, but it's very cool. This is a natural product that our body makes that actually is going to be sort of an answer to this problem, and probably a good thing for preventing cancer and preventing obesity and all these things. So it's a really interesting supplement.
On a different subject, like the same thing I found when I was researching hair growth, because as I was getting older, I was noticing what a lot of women and men, of course, notice. And I found the DHT blockers, and I thought, wow, this is, and saw palmetto. And I thought,
right. Oh, this is the answer, right? And then you realize all your testosterone levels dropped, right?
Right. It's true, because I have a very high testosterone for a woman. I've always been told that I'm way up. And then this last blood work was lower.
Yeah.
And I think it's because I've been taking these DHT blockers.
Right.
So.
Yeah, it's a problem, right? I mean, you're right. It's a problem for men too. Is the upside of you don't lose your hair. The downside is when you completely block DHT, that's your anabolic hormone. I mean, that's what makes muscle, right?
Yeah.
So it does help. What they've shown is very low dose finasteride. So using a very, very low dose, or using just a topical finasteride, you get less of that effect. But I have the same problem. I mean, it's like, I don't like to block my testosterone, and yet, it works great for helping hair loss.
Exactly. So you've got to kind of a catch-22.
Yeah, it's just kind of,
I know.
You're right. You're right. We do something that's affecting another pathway. And I will tell you, guys don't get told this, right? They don't get told, by they go to their doc because they're losing their hair, and he puts them on finasteride, right?
Yeah.
And nobody tells these guys that finasteride is going to completely, screw up your
testosterone.
Yeah, and your sex drive is going to go down, and your muscle building.
Yeah.
And some guys, and I have a 20-some-year-old, it becomes a permanent issue. You can't reverse it. It's called finasteride syndrome, and post-finasteride syndrome, and it's a hassle when it happens.
Well, so you've touched on so many topics. I want to focus on two very important ones, and three actually. One is bioidentical hormones. The second is peptides, and then the subset of peptides would be the bioregulated peptides out of Dr. Cavinson's lab in St. Petersburg. And then the third is kind of maybe summing up our talk today is skin aging. Because I'm an avid reader, and I tell you, I go on the internet, and it's every other internet site is about skin laxity or losing collagen, and there just seems to be so many dead ends and very expensive dead ends. So can you just take those three subjects and give us a little dissertation on each?
Yeah, I think
starting with
let's start with bioidentical hormones.
Mm-hmm.
So my belief, and not everybody agrees with this. So we have this course called Human Optimization Academy. In it, we have this what to fix first, because I would have all these people coming to me, who they're the Dave Asprey biohackers, right? And they literally had 4 pages of biohacks they were doing, and they still felt horrible. And I said, well, your hormones are still shitty. So, let's start there. And the debate is, well, do you start with sleep and nutrition? I actually will say that lots of times when I have, for instance, a menopausal woman come in, or a guy, a fat guy who can't get into the gym, for me to just say you just got to get to the gym and eat better, it's just not going to go over.
Exactly.
So basically, if you're a menopausal woman who has no progesterone, no testosterone, and I'm telling you to sleep, get a good 8 hours of sleep and go to the gym, you can't. You're like, I can't sleep. I can't get up and go to the gym. If I go to the gym, I don't make any muscle anyway. It's disappointing. And these people, and then they get fat and they feel more and more miserable. So I usually start with looking first at, and it depends again at the age, but looking first at hormones, getting those to a point where, they're at an acceptable range that now I can sort of start getting that person, they're in a receptive state.
Mm-hmm.
Where I could say, okay, now you've got progesterone on board. You should be able to sleep a whole lot better. Let's get you into a good sleep routine. You've got testosterone and estrogen on board. Now we can get you into the gym, and you can actually make some muscle when you go to the gym, as opposed to going and spinning your wheels and just getting sore every time you work out. So I start there. Now, I think there's a sort of this big kind of myth in bioidentical hormones, because, and the only hormone that really is not bioidentical, if you get it from a pharmacy versus a compounding, is progesterone. Now that's a big difference. Progesterone is not progestin. And anything any of the, Premarins or birth control pills, or Provera, those are all progestins. Progestins are not identical at all to our progesterone. And in fact, they will have some similar effects on the uterus, but progesterone receptors are on our brain, they're on our joints, they're on our ligaments. So basically, if I give progestins, it even lowers my progesterone further, because now my body thinks it's getting something, but it's not the same. And it isn't seen the same way at all, because it doesn't look anything like my progesterone. It actually acts more as a carcinogen. So progestin is very linked to cancers. It's not beneficial. It doesn't help mood disorders. It doesn't help joint pain. One of the big causes of joint pain is low progesterone. And so you've got to use bioidentical progesterone, not progestin. But people talk about bioidentical estrogens. Estradiol is estradiol. I don't care if you get the estradiol patch from your pharmacy, or I compound it for you in a cream, or, estradiol is estradiol. There's not a different form of it. So I think that functional medicine doctors have kind of got into, you have to get this estrogens from the compounding pharmacy. If I have women who it's cheaper and easier for them to get, an estradiol dot or patch or cream from their pharmacy, so be it. Lots of times it's cheaper for them to get it from a compounding pharmacy. Not always. And some women find it more convenient to use a patch. So estrogens are estrogens and testosterone is testosterone. Big difference is that I can dose things exactly the way I want them when I get them from a compounding pharmacy.
Yeah.
So I can much more specifically dose it as opposed to using this is the doses it comes in, right? And then usually for women, there's not really any testosterones over the counter for women. They're designed for women. So those really have to get compounded. Now, the other thing to always remember, because I still see a lot of women on oral estrogens, and oral estrogens are the one thing I'm not fond of. Because when we look at the risk of blood clots, strokes, embolic events, that's the oral estrogens. There is not one study to show that transdermally applied estrogens create any change in blood clot risk or stroke risk or heart attack risk. But there is with oral estrogens. When they go through the liver, they can be damaging the liver. They also have an ultra byproduct that affects blood clotting. So I hear this all the time too from the primary care docs. I'll put my woman on transdermal estrogens, and then they say, oh, you have a stroke risk, you shouldn't do those. And I challenge the doctor to show me an article that supports that, and they never do, but they still continue to say it. So, you've got to look at scientific evidence. And if you look at scientific evidence, oral estrogens are linked to blood clots. Transdermals are not. Progesterone can be done transdermally or orally, but orally crosses the blood-brain barrier, and it's more soothing to the brain, more anti-inflammatory to the brain, helps women sleep better. And then testosterone usually done in either as an injection or transdermally. Usually women, I do transdermally. And the other thing you have to remember is that men need all three of those hormones too, just like women, right?
And DHEA and sometimes thyroid.
Thyroid, exactly. Those all have to get balanced, right? So yeah. So I always start there when I'm looking at what do you need to actually get this down this longevity road, right? And then we start working on, getting your nutrition properly. And that's eating a lot more protein than you think you need. I mean,
I'm so glad. Yeah, I'm so glad you brought that up, because that was another topic I wanted. This is the problem. We're going to have you back on. But as long as you mentioned the protein, that's another thing that's right now extremely timely, because there's all these products or weight loss things that like Ozempic or whatever. That basically are making you lose muscle, or you go on the caloric restriction or the intermittent fasting or the OMAD, 1 meal a day.
1 meal a day diet, right?
And all those
people are becoming protein deficient. I totally
agree.
Agree.
And so what's going to happen with people? They're going to lose muscle
and bone. Bone is really important. You have to have protein. I mean, when I look at my elderly patients, and I have them actually write down the amount of protein they're gaining a day, sometimes it's like 30 grams. I mean, we need more protein as we age, not less. Right. So, I tell people, good number to aim for is 1 gram per pound of body weight. I weigh 135 pounds. I need 135. I work out a lot, 140 grams of protein a day. It's right to do. There's no way you can do it in 1 meal a day. And it's one of the reasons I'm not a huge proponent anymore of intermittent fasting, is because I've seen too many people become protein deficient. I think it can be sporadically. I think if you're doing it on a regular basis, where every day you're only eating within a 2-hour window or 3-hour window, I think you're going to have a really hard time not becoming protein deficient. So I think there's some benefits to it. Don't get me wrong, but I think you have to be really careful. Yeah. Now, I'm a huge fan of Ozempic, or semaglutide. It's a GLP-1 agonist. It has huge health benefits. It actually will help you put on muscle and lose fat if you push protein. And I can tell you, if you've tried the drug, it is really hard because you have zero appetite. So that is the biggest problem with it, and why people do lose muscle mass and why it's gotten sort of criticized by. It's because you look at people just stop eating. They just don't want to eat. It's very hard to motivate yourself to eat.
But I saw an article. I was watching a podcast actually about Ozempic, and they said that the one girl who was trying it, she said, you'll be burping all the time. You might have some mood changes. You will lose muscle. I mean, she went on with all these things, and I said, why would anyone want to take the GLP-1? If you're going to have all these side effects? Because for me, I don't like to do any drug. I don't do any pharmaceuticals. I mean, none, zero, never have. When I go to the dentist and they give you an antibiotic, I stick it in my pocket. If they're going to, they don't know that, but it's just like, to me, it's just like, I can always find an alternative, I hope. But, for weight loss, it seems like this is the name of the game right now, that it is a diabetes.
So I'm going to be the devil's advocate to you on this one, because
I want you to be.
So number one, Google GLP-1 agonists and health benefits. The way they got discovered was they were under discovery for treating dementia, and they worked very, very well. But the people they were treating lost so much weight, it wasn't at the end. You have these people who weren't eating anyway, that it wasn't an effective drug. They're still looking at it in terms of using it for cognitive decline. So it's still it's back in trials on that. But basically, the drug company said, "Oh my gosh, there's a lot more people who want to lose weight than don't want to be crazy or be demented. So we'll go after the weight loss side." So that's how they got discovered. But if you look at their benefits, just, I always have this great little picture I show my patients. It shows what GLP-1 does. So it helps you form new neurons. It helps cardiac output. It helps turn white fat into brown fat. It helps build skeletal muscle. It improves insulin sensitivity. It helps liver functions. Great for people who have fatty liver disease. So it works on almost every organ system because there are GLP receptors on all of these organs. So if you look at up-regulating GLP, it has so many health benefits. I take a low dose of it all the time, not for weight loss, but because of its benefits for protecting my organs. So
that's interesting.
For my brain, I have a history of dementia in my family, for my brain, for my heart, for my liver. I take a small dose all the time, not so much that I get lost of appetite, but a small dose.
Do you do it orally or injection?
Injection. Now they are coming out with a new oral one. There is an oral older form, but they are with a new oral one. Now the people who get the bad GI side effects, because they can be bad, and sometimes they go away. Usually they're worse if you eat badly. So if you eat a lot of carbs and things like that. So if you're eating a more healthy diet, you don't see that as much, but they still can be bad. So they now came up with the next generation, which is what's called tirzepatide or Mounjaro in the pharmaceutical world. That's a combination of a gastric intestinal peptide with a glucagon-like peptide. And that two together does not cause the side effects. So you get the same benefits of the GLP-1 without getting the GI side effects. And it's more effective for weight loss. The downside of that drug for me, taking it more for my health benefits, is that it even at a low dose, it makes me lose my appetite. It's hard for me to eat. So
you don't need to do that.
So basically, if you look at and then I say, okay, so a lot of my family has the FTO gene, which we sort of have fondly named the FATO gene, because the FTO gene, people have the FTO gene have a hard time turning off eating, right? They just basically, if there's food there, they're going to keep eating it, right? It's there, they're going to keep eating it. And so that's one of the things that we know. They have a little bit different brain chemistry. Well, one of the things that Ozempic does is it alters the genetic expression of the FTO gene. So here I have a gene that's potentially making people have a really hard time stopping eating, losing weight. And I have something that changes that gene. To say I shouldn't use it, to me, is a little bit like, wow, I could cure your disease, but I'm not going to, because you should just try and do other methods. I mean, when you've got the epigenetic modifications, now those can stay oftentimes after you stop the drug. So if you stop the drug, you'll see people have a much better ability to stop eating. It's made an epigenetic change in them. And so I love these drugs.
Yeah, so I'm so glad that we got on this subject, because I didn't plan on talking about it, but when you brought up protein, I thought, oh, this is really timely but so I think a lot of people would be very interested in talking to you about, can they do that through telemedicine if somebody
I'm licensed in 48 of the 50 states. So we have patients actually all over the world. We've got patients in Canada and London and Australia. And New Zealand. So we have patients all over the world. So, I would say a large number of our patients are not, are even orthopedic patients. Sometimes they'll fly in for procedures, but we'll look at their x-rays and things like that. So we're very equipped to do telemedicine. It's mostly what we do.
That's great. So tell us about skin laxity, collagen, and
tough, right? Yeah. Elastin. I mean, so that's a tough one. And that's where when you look at Ozempic face, why do people get Ozempic face? It's because they lose fat, right? And what really holds our face full is fat. So it's tough, because that's that whole, I can't remember what movie star said that years and years ago, right? You can either have, was that Marilyn Monroe? If you look at people who are a little pudgier, they look younger. I mean, right? They just have more fat in their face. Right. And so hence the advocacy of fillers and things like that. But then, it's pretty hard to duplicate what fat looks like on our face. Right. So fat transfers have helped that. So can I change the fact that you are losing fat a little bit as you age, if you're seen on the thinner side, no. And it seems to be preferentially that a lot of people, as they get older, will lose more fat from their face and potentially their butt. So that's a tough one. You either got to carry an extra weight or look a little bit saggier and older. And I think, unfortunately, that's where some of the answers to that are, do you have to do things like fat transfers and things? But obviously, hormones are going to help maintain that a lot more, right? So estrogens, progesterones, things like that. For skin laxity, I think we're hitting a whole new sort of realm in that. And there's some really good peptides that are helpful there. For instance, there's a peptide called GHK copper. GHK copper is what helps collagen. It's what makes collagen healthy in our body. So you can give yourself injections of it to sort of help all over. But you can also use a GHK copper skin cream. And you can mix that with things like argireline and Lufazol, which act like Botox a little bit in your skin. So those are peptides that have a Botox-like effect. So that sort of the fine lines, the fine lines gone, and GHK copper, again, naturally made by our body. So I like peptides that are naturally made by our body, right? So they're not something foreign to us. So that's how our body repairs collagen, is with GHK copper. So that's great, and then I think one of the things we use a lot of is, you might be familiar with rapamycin or sirolimus. And rapamycin's gotten a lot of play in the longevity world because it blocks what's called mTOR. And when mTOR is accelerated, mTOR stands for mammalian target of rapamycin. Hence, rapamycin sits in mTOR, turns it down, and that slows aging. So almost every longevity doc is gotten on board with rapamycin. It appears, we don't know for sure, but appears to be a really good way to delay aging. Well, you can do rapamycin topically as well, because it really works in skin cells as well to help kind of kill off all the senescent dead cells. So if I use like a combination of GHK copper skin cream and rapamycin skin cream, I can do a lot, for helping people's skin or collagen integrity. But the GHK copper is probably the best for collagen integrity, and then the sirolimus skin creams to kind of get rid of the older cells so we can regenerate newer, healthier cells.
So do you actually supply that to patients?
Yeah, so we have compounding pharmacies make it for us. Yep.
Yeah, the combo.
Yep.
Oh, that's incredible. Okay, I didn't even know about that. And then, okay, so let's move on to peptides now, since we touched on it, and I don't want to run. Let me just look at we have like 4 minutes. So give us your quick primer on you touched on BP 157, you touched on the copper. What about the 1295?
CJC and ipamorelin. So again, one of my when I talk about aging, one of the things I always say is repair what we lose or replace what we lose, right? So we lose estrogen, we lose testosterone, we lose thyroid, we lose progesterone, we lose peptides as well. Yeah.
Right.
So people think of peptides like a pharmaceutical or something we don't have, but we make peptides.
Right.
We make BPC, we make thymic peptides, we make insulin-like growth factor. Those are all peptides that our body naturally makes, just like insulin. Don't forget, insulin is a peptide.
Exactly.
So basically, I'm a big advocate of replacing at least those peptides periodically. So in my longevity patients, we will put the sort of series of peptides. So sometimes I'll use like BPC with thymosin beta 4 to repair an injury, but lots of times I'll just cycle people on and off of those through time, because as I age, I make less of them. So if I want to replace what I had when I was young, they're included. So those include things like the thymic peptides. Yeah. Babies, we have a giant thymus gland in our chest.
Yeah.
It controls our immune system. It's, but by the time you're, my age, it's a calcified little nub. And so basically, I got to get back what the thymus gland makes, things like thymulin. That would be one of your bioregulators, or thymosin alpha 1 or thymosin beta 4 are sort of more distinct forms of that. BPC, which is made by our gut to help us repair tissue, help our brain, improves BDNF, improves gut. So basically, you can do BPC either as a subcutaneous injection or orally. Works better musculoskeletal as an injection and orally for gut.
Right.
And then I'm gonna decline in growth hormone as I age. Even if you're doing everything right, exercise and everything, you're going to decline in growth hormone. So better than giving growth hormones. So probably giving growth hormones, it's very, very hard to dose it so you don't have these very high surges. We don't high surge growth hormone and get these very high levels of IGF. That's probably not good for you. It's probably pro. And so what we use are what are called bioregulator peptides, which are CJC and ipamorelin are basically, they're going to encourage your own pituitary gland to make and release more of the growth hormone. So now I use my own body to release more growth hormone, increase IGF levels. So CJC, ipamorelin, usually I'll have people do those pretty continuously, 6 out of 7 days of the week. They do a little injection before they go to bed at night. Helps with sleep, helps with recovery. Really great if you're not sleeping well. Getting growth hormone levels up at night is really helpful there. So those are kind of base ones that we use in almost everybody. And then when we talk about mitochondrial dysfunction, I cycle a lot of my clients on what's called a mitochondrial peptide. It's called MOT-SC. So our mitochondria make peptides too. MOT-SC tells your body to make new mitochondria. It's in pharmaceutical trials as an exercise mimetic, so it actually acts like exercise. So people who can't exercise, they're too debilitated or they're laid up in bed, you can actually give them MOT-SC and it acts to their body like they're exercising. So you get mitochondrial biogenesis, healthier mitochondria. So basically you can use that, cycle people on and off in that to kind of replenish some of that mitochondrial function. So those are kind of the go-tos. And there's 2,000 different peptides we use.
I know it gets confusing, but those are the basic ones. And
those are basic ones. BPC, the thymic peptides, the growth hormone peptides, CJC and ipamorelin, and then I like the mitochondrial peptide.
So before we go, I know you wanted to talk to us about a little gift for our viewers, and could you just take a moment and just tell us what that would be? Because I think it's so generous of you, and I just want everybody to know.
So, guys, one of the things we've done is because we realize that people are so like people like you, Michele, appreciate that you're getting out there and spreading this word so people learn it, because you can't learn this stuff from your doctor, right? And if you talk to your doctor about it, usually they'll just ignore you. And there's a few doctors who are good at it, but not a lot. So what we decided is we would put together a course that really helped people understand. So we have a peptide course and a hormone course. And so if you join what's called our Human Optimization Academy, it's an academy that's designed to kind of turn you into a doctor in a sense. You're still going to probably need a doctor, but basically make you understand this stuff. It's all taught from scientific knowledge, basically literature only. It's none of my opinions. It's literature. So teaching you the peer-reviewed literature so you can make logical decisions, so you can learn this stuff. And there's courses on everything you want to know. There's orthopedics. How do we deal with orthopedic injuries? What if you have an ACL tear? And then we do these monthly Q&As, which are really fun because honestly, this group is so smart and they ask the best questions. They keep me on my toes. There's a lot of physicians in the group now too. So by joining that, you guys can actually really learn this stuff, at least to a degree where you can talk about it and understand it. Because you're going to have to take charge of your own health. I don't think you can rely on somebody else to do it. So
and make better choices because it's so
make better choices, right? And so if you go to Human Optimization or BLI Academy, so BLI.academy, you put the code Ageless 10 in there, they'll get a 10% discount on the membership. It's not a super expensive membership. We've tried to keep it so it's very doable for people, so we can start spreading this word and having people learn this stuff and not. I think the problem with learning from Instagram influencers is they're being paid to say what they say a lot of times, and people need to start learning from scientific data.
Right. Perfect. Okay. Well, we have to end. Sadly, I could talk to you for another hour easily and still not run out of things to say. So, Dr. Yurth, I just want to say you are a truly amazing doctor. One, because you combined your two specialties into something it's like a gestalt, the sum is greater than the whole is greater than the sum of the parts. So thank you so much for doing that. And a lot of people go around with injuries that don't know how to heal them.
Please, if you guys have knee pain, joint pain, you're like facing and they've told you all you can do is replace the knee, please call us because there's so much more.
Thank you.